I am Dr. Shruti Nayak, Additional Professor from Department of Oral Pathology and Microbiology, Yenepoya Dental College, Yenepoya deemed to be University. Going to have a discussion today on the topic tuberculosis. So to start with the specific learning objectives, at the end of this discussion, the student should be able to enumerate the different types of bacterial infections affecting the oral cavity and describe in detail the etiology, clinical types, clinical features, pathogenesis, oral manifestations, and histopathology of tuberculosis. So to start on with what is the bacteria introduction, they are the prokaryotic microorganisms which can be spheroidal, that is in the form of coccus, or in a form of a rod or a cylindrical, which is called as bacillus, or in a spirilla form, that is called as spirochetes. They are the most causative agents of many human diseases. So in this picture, we can see that the first picture shows the single cocci, which is in a single cluster, and next you can see it at the streptococci, which are in chains, and with the next one, that is the staphylococcus, which are in the clusters. In the next picture, we can see the bacilli, which is in the form of rods. These are some bacterial infections which are very much commonly seen in the oral cavity, that is called as causing the oral manifestations, which includes tuberculosis, syphilis, actinomycosis, scarlet fever, leprosy, diphtheria, and cat scratch diseases. So the topic for today will be the tuberculosis. So tuberculosis is a chronic, systemic, infectious disease of worldwide prevalence. It is a granulomatous infection and is caused by Mycobacterium tuberculosis, or rarely by Mycobacterium bovis. Incidence of tuberculosis has greatly declined recently. In patients with AIDS, we have seen that the Mycobacterium avium intercellulare is the most commonest cause causing the opportunistic infection. To move on with the pathogenesis, this is caused by Mycobacterium tuberculosis, which is an aerobic, slender, non-motile, non-spore-forming, rod-shaped, acid-fast organism. The mode of spread is nothing but the droplet infection. Since tuberculosis spread through droplet infection, the optimal condition for transmission includes the overcrowding, poor oral hygiene, poor personal hygiene, and the poor public hygiene. Mycobacterium tuberculosis species is the picture what we are showing here, the slender rod-formed bacilli. The contributing factors for tuberculosis includes the social issues, that is poverty and overcrowding, political issues, health issues, economic issues, and mycobacterial issues. So the patient with active disease expels the bacilli into the air in the form of coughing, sneezing, or shouting. Even screaming can cause this. Once inhaled by tuberculin-free person, the bacilli multiply in 4 to 6 weeks and spreads throughout the body. The bacilli implants in the areas of high partial pressure of oxygen, that is the lungs and the renal cortex. This is the picture where we can see the person just talking or screaming or even sneezing and coughing can cause the spread of infection. So this spread is called as the primary tuberculosis. The lesion will heal and a scar will appear in the infected loci. The bacteria at this time goes into a dormant state, and when the person's immune system is depressed because of some secondary reactivation, then it is called as a secondary tuberculosis. Sometimes the infection will disseminate and go through the various vascular channel and to other parts, which is called as the miliary tuberculosis. Now we'll move on to pathogenesis, how the infection spreads. The first, as we have already discussed, that is the airborne droplet infection that causes the next stage of tissue hypersensitivity to the bacilli and causing to transient inflammatory reaction in lungs. And here the polymorphonuclear nucleoside, that is the macrophages, comes into picture. These macrophages will phagocytose the organism and the bacilli will start to multiply within the macrophage. So this will cause the formation of epithelioid cell, and these epithelioid cells will fuse together to form a Langhans type of a giant cell. Then in the center, the caseation necrosis will start to form, and surrounding you can see the lymphocytes and fibroblasts accumulate in the periphery, leads to formation of a granuloma, which is called as a tubercle. Most of the lesions heal by fibrosis and calcification, but Next, the microorganism may remain dormant for a long time, and this is called as the reinfection as a result of reactivation whenever the patient's resistance is decreased or suppressed. So this is called as a secondary tuberculosis. So in this picture, we can see a granuloma, which is called as a tubercle, where we can see a central caseation necrosis surrounded by epithelioid cells, lymphocytes, and fibroblast. One more picture to show the histopathology of same. Anyways, the epithelioid cells are the macrophages which are converted, and these macrophages will join together to form numerous Langhans type of a giant cell, wherein we can see in the picture. To go ahead with clinical features commonly occurring in adults. So primary tuberculosis is usually asymptomatic, and secondary tuberculosis shows features such as the general features include fever, weight loss, anorexia, night sweats, and weakness. When we go to the organ-specific symptoms, those are the lungs-related, causing pneumonia, which is the most commonest symptom, followed by the lymph node involvement, that is called as scrofula. Sometimes the genitourinary tract is infected, sometimes the bone, and also brain. Very commonly seen is involving the skin, which is called as the lupus vulgaris. So oral manifestations. As dentist, we are concerned about the oral manifestations or features seen inside the oral cavity. Here, the occurrence of tuberculosis in oral cavity is quite rare, because the oral cavity normally happens in the form of secondary infection. The primary tuberculosis may not occur here. The reason being is the intact oral mucosa does not permit the tuberculous bacilli to enter into the tissue, but the pre-existing oral lesions may facilitate the entry of these organisms into various oral structures. The oral lesions which are that pre-existing can be in the form of oral ulcers, or even the dental abscess, cyst, or even the periodontitis. So this can facilitate the entry of the organism. Organism can reach through the blood spread, that is the hematogenous route, to the submucosa, subsequently causing the ulceration of the mucosa. So the most commonest oral manifestation of tuberculosis include tuberculous ulcers, tuberculous gingivitis, tuberculous osteomyelitis, and tuberculosis of salivary gland. Some symptoms, some other lesions include the nodules, vesicles, fissures, plaque, granulomas, or varicopapillary lesions. Coming to the tubercular ulcers, which are the most commonest form. So single or multiple ulcers which are irregular, superficial, or deep, painful, and tend to increase slowly in size. They have a granulating floor with minimal induration, and surrounding mucosa is inflamed and edematous. May occur in any intraoral sites. However, tongue is the most commonest site. The other areas in the oral cavity which can be involved can be the palate, buccal mucosa, gingiva, lips, alveolar ridge, and the vestibules may also be involved. Coming to tubercular granuloma, it is seen as a soft, non-tender swelling, may occur in any intraoral site. Palate is the most common, may develop in the periapical region of a grossly decayed tooth due to the entry of organism into the pulp canal. So this is termed as tuberculoma or tubercular periapical granuloma. Tuberculous gingivitis, those are the small granulating ulcers or erosive lesions which can be seen in the gingival interdental papillae areas and gingival hyperplasia. This is the picture where we can see the gingivitis because of tuberculosis. Tuberculous osteomyelitis. This may develop due to entry of organism through decayed tooth or due to hematogenous spread. So this may cause pain, swelling, or formation of a sinus or a fistula, trismus, and paresthesia. So tuberculosis of salivary gland. This is little less common, but still if it is present, it is going to cause generalized glandular swelling or abscess formation along with pain, facial palsy, and fistula formation. This is a picture wherein we can see the general involvement of tuberculosis overall in every part of the body. As I told before, the scrofula, it is involvement of the lymph nodes. This is something very much commonly seen. The enlarged oropharyngeal lymph nodes, that is the cervical lymph nodes especially, Here what happens? The necrosis begins, that is called as the caseation necrosis, and numerous draining fistulas can be seen overlying the skin, which are seen outside. So this is called as a scrofula, and overall involvement of the skin is called as lupus vulgaris, as shown in the picture here. You can see the skin becomes totally reddish, and that is called as lupus vulgaris. And the draining sinuses, because of the cervical lymph node necrosis, that is called as the scrofula. So in this is the scrofula picture. So some more pictures where we can see the involvement of tuberculosis in the central nervous system and the other areas, osteomyelitis. Coming to the histopathology, the microscopic presentation is in the form of granulomas. As we discussed previously, the granulomas, which are the circumscribed tubercular lesions. Granulomas have a central area of caseation necrosis surrounded by a multinucleated giant cell, lymphocytes and epithelioid cells. These epithelioid cells are the altered macrophages. These macrophages forms the most common surrounding cells. Again, surrounding those will be having the fibroblast. The same macrophages are going to join together, many macrophages, and they are going to form a multinucleated giant cell. In this, the nucleus are arranged in the periphery of the cell or in a form of a horseshoe shaped arrangement, and these cells are termed as Langerhans type of a giant cell. Then rimming those, you can see again the epithelioid cells, lymphocytes, and also the fibrosis along with fibroblast. This is surrounded by a zone of lymphocytic infiltration and fibrosis. So tubercular organism may be demonstrated in a tissue section by Ziehl-Neelsen or acid-fast staining. This is the picture in which we can see Ziehl-Neelsen stain, wherein we can see the central caseation necrosis, again the macrophages which are in a different shaped form cells, and the round cells which are the lymphocytes, and peripherally you can see the spindle shaped cells which are the fibroblast. This is the histopath picture where we can see beautifully necrosis followed by the other cells, and here we can see the different types of tuberculomas, that is 1, 2, 3, which is forming in a cluster surrounded by areas of fibrosis. So coming to the investigation, because this is an infection, especially involving the oral cavity, it is a bacterial infection, so we have to go for investigation rather than histopathology. So the first investigation, it starts with the staining of the smear prepared from the sputum, that is called as the Ziehl-Neelsen stain, and this stain is going to give a positivity for this particular microorganism. And the next, as we are told, it is involving the areas of higher oxygen areas where it is called as the lungs. So in our the main concern is the chest radiograph. So here the lungs are involved first and priority wise, so we can go for a chest radiograph. The next comes the culture or the colony forming. The bacterial culture is done in a Lowenstein-Jensen media. So material used for this culture may be the sputum, laryngeal swab, gastric lavage, urine, or also the cerebrospinal fluid and pus, etc. These are the materials used to culture and also for even the staining the same microorganism. Lately, after these three which are commonly done, we can also go for animal inoculation, which is less commonly done. Histopath also done very less commonly. The third one, which is very much concerned with tuberculosis, will be the tuberculin test, or also called as Mantoux test. For the reason related to research and investigations, the other things will be the ELISA, that is enzyme linked immunosorbent assay, and the polymerase chain reaction, which can be done for the form of research, not for diagnosis. So treatment by anti-tubercular drugs, which can be a different regimen in combination of 2-3 drugs for few months, will form the treatment regimen. So, to conclude, tuberculosis remains a significant global health issue due to its high infectivity, particularly in populations with compromised immune system or limited healthcare access. While tuberculosis primarily affects the lungs, it can spread to various organs, making it a complex disease with diverse manifestation. So effective treatment is possible with a prolonged course of antibiotics, but challenges like drug resistance and incomplete treatment adherence continue to complicate the control efforts. Prevention through vaccination, early diagnosis, and complete treatment adherence are essential for reducing the tuberculosis spread. So, the ongoing research and the public health efforts are crucial to combat this persistent and adaptable pathogen. To summarize, tuberculosis is an infectious disease caused by Mycobacterium tuberculosis, primarily transmitted through airborne droplets. The disease presents in various clinical types, mainly pulmonary tuberculosis, which affects the lungs, and extrapulmonary tuberculosis, which impacts other organs such as the lymph nodes, bones, and GIT tract. Tuberculosis clinical features in the form of persistent cough, weight loss, fever, fatigue, and other things. Pathogenesis involves the inhalation of tuberculous bacteria, which are engulfed by alveolar macrophages in the lungs. Some bacteria survive, leading to granuloma formation as an immune system tries to contain the infection. In oral manifestations, tuberculosis can cause ulcers, nodules, or lesions, particularly on the tongue, gingiva, and lips, although these are rare. Histopathology reveals granulomas with central caseation necrosis, Langerhans giant cell, which are characteristic of this lesion. Thank you so much.